Hello and welcome to another episode of 4 Wales, See Wales with me, Mel Owen.
Me, Robin Morgan.
And me, Will Hayward.
And me, Matt Morgan.
Matt, welcome to the podcast.
Thank
Your
you.
first time on.
It's my first time. Excited.
Oh, can we call you Matt?
Yes.
Yeah,
yes.
not Doctor.
No.
Not Doctor. Matt Morgan, relation of Robin Morgan?
I don't think so, but possibly.
With
the glasses, maybe.
Yeah, the DNA is still outstanding.
Very strong.
White man with glasses.
I wonder if we are related. There's lots of Morgans in Wales, but maybe.
I'm from Neath. My dad travelled quite a bit,
I never met my dad. Yeah. How's your mum is the question you're asking me. Great. Interesting. My dad is from Ricos, so it's slightly more north, but who knows? We'll do maybe we can do a live ancestry test.
Yeah, a 23andMe on the show.
Leave some blood before you go, please. And I say that to every guest.
I always do.
Yeah.
I'm going to do a very icky thing, and I'm going to read your bio to you. You might have written this, in which case you're welcome. So Matt Morgan is a consultant in intensive care medicine, an honorary professor for the public understanding of medicine, and a regular. This says BMJ. I reckon that's British Medical Journal columnist.
Spot on.
What are you doing here, Matt? You're very overqualified to be on the podcast. Thank you.
Well, sunny Newport.
Exactly.
I brought Welsh cakes, so it's all good.
Thank you so much. We are very excited for them, actually.
How many guests have we had bring presents?
I think Rena Corn.
Oh, some corn.
But that was really to mock us.
That was, yeah.
Do you know what I mean?
That was a classic power move.
It was. He gave you some sweet corn to put on your head.
Yeah. Where is he now? Who else has given us gifts?
Did Matt Wall bring anything?
Oh, Matt Wall bought something from Germany.
Yes.
They were delicious, to be fair, but Welsh cakes are banging.
There's a story behind the Welsh cakes, actually.
Oh, come on.
And I was quite cross about it, so I'm glad I can air it here.
Oh, great.
Please,
Perfect.
yeah.
We came to see your first live show, and we entered a question. There were lots of very clever political questions from an engaged audience.
Yeah.
And the question we asked was, should you choose Welsh cakes from Cardiff Market or from Fabulous?
Oh.
And you didn't ask it. So that's why I've brought the Welsh cakes, but I couldn't bring the ones from Cardiff Market too. So it's not a fair trial.
Interesting. Do you have an answer to your own question?
I do.
Should we do our poll first and you can decide who's right?
Yeah, I mean, I'm Market.
I'm Fabulous.
I'm neither.
Who are you?
Cakes?
I am Rogue Welsh Cakes, who sell in Newport Market, just down there.
Is that the one you have shares in?
No, I don't. I know the guy who owns the company. They're
Yeah.
delightful. He does cheese and leek ones.
Oh, no.
He
What
does-
is your problem?
He does original, but he does a whole range of flavours.
No.
You can get them as meals, and he heats them up and does it with a little poached egg on top. It's a delight.
That sounds
You're
like
an
a
animal.
war crime.
No. I will have no slander. Daryl, fire her. They're delightful. I'm a rogue guy. That's it.
Okay, Matt, I can only apologise for what just happened.
Is it too late to leave?
No.
Yeah, please
not
do,
At all.
please
Leave
do.
your blood, please, Matt.
Who would you go for?
So I'm sorry to sit on the fence, but the trad, I'd go for Market, and chocolate chip, I'd go for Fabulous.
Okay, well, there we go. So everyone's a winner except Robin. Yeah.
What a Lib Dem answer.
Very.
So let's talk about how the obesity crisis in the Welsh NHS.
So, Matt, you've got so much experience working within the Welsh NHS, and obviously it's one of those things that is used a little bit as like a political football, I would say as well. Like, we talked quite a lot about how previous Westminster governments have pointed and gone, well, look at the Welsh NHS, if that's what you want. What's your overall experience of the Welsh NHS and how it's looking?
Yeah, I guess the first thing to say, and I know this is obvious, but it needs to be said, it's not one thing.
Okay.
There are over 100,000 people who work in the NHS. It's not just a couple of people here and there. There's over 12 hospitals. There's 340 GP surgeries. It's a massive enterprise. It's a population the size of Exeter. So, of course, you're going to have massive variation. And I've seen amazing things and I've seen terrible things. You've seen every spectrum of life. And it's also an incredibly complicated thing to deliver. I was trying to think on the way here, what else is more complicated to deliver than healthcare to a nation? And SpaceX was on the radio, actually, and that's got a population the size of Penarth. I've come from Penarth today. It's much less people. It's 10,000 people, and all they are trying to do is go to Mars. They're just trying to do one thing one thing that's complex, but just one thing. And yet you've got this beast of an NHS that's trying to do everything for all people all the time, 24 hours a day, with every bit of society. So, and I think we kind of forget that. When an Aaron Bevan stood in Tredegar with the Medical Aid Society promising care for all he had to offer was probably 4 things, really. He had antibiotics, which had just come around. He had a couple of other drugs, maybe. He had some operations, not many, and he had a bit of public health. There was just those things. And now the problem we're in is actually because the NHS works. It's kept people alive. We've got an ageing population. We can do amazing things, and that's caused the problem. There's not many businesses that cause their own problems. It'd be a bit like an insurance company that needs to pay you an annuity for the rest of your life, also trying to keep people alive.
Sure.
So that it destroys their own business. It's a crazy prospect. So I think we forget that, actually.
How well do you feel that the NHS is performing in Wales at the moment? Because obviously we hear about waiting lists a lot. That's something that is very close to people's hearts when they're voting and so on. We hear all the time about how the Welsh NHS is the worst in the UK. But like you say, you see amazing things happening within the NHS as well.
Well, the data doesn't lie. We know there are 600,000 people on a waiting list. I think it's been crazy, like 1 in 5 of the Welsh NHS population. Some markers are objectively worse than other systems, whether it's cancer care, whether it's maternity care, whether it's other things. So, yeah, there are absolutely real issues. But I think it's also important to look at some of the data which still says, compared to other big international systems, the NHS actually is quite efficient and has quite good outcomes, only behind Australia and Netherlands in some of those data polls, for example. That's not to say it's great and not to say there aren't massive issues, but I think we need to remember that. And ultimately, although it's incredibly complicated, there's probably only 4 things you can do, to help. You tax more, which is what the Danes do. They tax loads, much more than we do, and they have good education and healthcare. Or you ration, and that's what the French do, and we ration to some degree. Palliative care is charity funded. The Welsh Air Ambulance is charity funded. We already ration. Dentistry is absolutely. Or you collaborate with industry, and that's kind of what Australia does in their model. And actually we kind of do here, we're just not honest about it.
Is that what, when people say privatisation, is that a similar thing?
Yeah, there's always healthcare that's delivered by private companies and non-governmental companies, but there are different ways to do that. In Australia's Medicare system, where I've worked for a bit, they actually pay the private companies a percentage of what it would have cost, say, to have a knee replacement done. And what that actually does there, kind of works in that it offloads the public system and it produces quite efficient throughput, because that's what commercial industry sometimes delivers is efficiency. Not to say it's all good, and there are issues with different standards and so on, but that's what they do. And the 4th way is efficiency. And so there's only really 4 solutions to the problem, if you like.
Sure.
How does it feel, as someone who's worked within the NHS for so long, when, as Mel said, in Wales it's used as a bit of a stick to beat the Welsh government, and the sort of the criticism, I suppose, in my, I grew up with free healthcare. I think we all were all born within that. So I think it's interesting that the NHS has kind of criticised quite a lot, especially in the last few years. How does it feel on the ground to be within it, having that? Does that noise get onto the ground in terms of the criticism?
It does, but I think people generally do disentangle systems, politics and people. There's very few bad people in the NHS. What there are bad incentives, bad systems. Not to say there aren't any, people who have issues with their care or criminality or whatever else. There's 114,000 people, so you're going to have every slice of the population. But I think when there is criticism, us as staff, I think we often agree with that, especially around infrastructure and waiting lists. We don't want that. And all of us are also patients in the NHS. My dad's just gone through skin cancer surgery, for example. My children have been involved in the NHS. So we're not just a member of staff. We're both things at the same time, really.
In terms of what do you mean by bad incentives?
Well, I'll give you an example. The way the structures are set up in Wales, there's 7 health boards for a population the size, Greater Manchester just has 1.
Right.
That sets up already lots of bad incentives, not on purpose, but the way it's just been cobbled together. Spinal surgery, for example, the cost just of the equipment of some forms of spinal surgery is many times more than the tariff certain UHBs pay to others to have it done. So the more work you do, the more money you lose.
What you mean there, if a health board didn't deliver that and they were paying another health board to do it for them, they're actually paying less than the cost of it. So the health board that's doing the procedure is out of pocket.
Correct. And this is, all through the system. And again, it's not because the people are bad, the clinicians, or all the managers. We need both of them. This isn't a manager bashing thing. They're really important. But the system has been cobbled together since 1948 and just built up and and has developed these inefficiencies, these system errors, these bad incentives, really. And that's just one example of that.
Interesting. So, I mean, any sort of big organisation that has, existed for decades upon decades, I suppose these things will happen. You gave those options of what to do. Does it need this sort of cross-party thing of like, right, let's strip it all back and work out what to do again, like Etch-a-Sketch the whole thing? Like, what's the way to sort of fix this?
I come to it as if it's my day job. So if I go into intensive care where I work, it's 3 a.m. and you are referred a patient who's critically ill, there are 4 super important steps. Number 1, you have to recognise that. So you have to recognise that somebody is sick enough to die, somebody is critically ill. And I think the new government has kind of done that. On the BBC Wales interview, they've said, look, this is bad. This is a real issue. So you need to recognise critical illness. Then you need to do something super important, which is be honest about it. And I think they've done that too. You have to admit the problems you found. And then you need a diagnosis, work out what's wrong, and then you need a treatment which doesn't just look good, but a treatment which is effective. So I think, the new government has definitely done the first 2 of those pretty well, actually. And they've started with the second 2. They've announced today elective surgical hubs, for example, which disentangles the messy acute care of somebody who's critically ill from planned care. And that's a hard thing to do side by side. So that's a step in the right direction. And really importantly, a bit like in Aaron Bevan, he came up with this partnership model where clinicians and nurses working side by side in this planning. They've announced a panel which includes clinicians, nurses, surgeons, anaesthetists and so on. So I think that's a step in the right direction, but there's a load more needed, really.
Can I ask you about, you talked about working with kind of the private sector. Just kind of 2 things I wanted to ask you about that. Part of when you say about the private sector taking some of the elective surgeries backlog, I've heard that one of the frustrations of people who work in the NHS is that the private sector will take the easiest jobs, which leads for very complicated things for the NHS. And then how much do you think it's an issue that as we expand private sector provision, how much that pulls resources in terms of, if doctors say, actually, we're going to split our time 3 days in the private sector, 2 days in the NHS, it makes it harder for the NHS, which in turn means they rely more on the private sector. How much of this do you think is an issue?
Yeah, well, what you're getting to, which is super important, is the NHS isn't just a waiting list. It's not just planned stuff. There's also the messy stuff. There's somebody who's critically ill at 3 a.m. There's a mental health crisis, on a Saturday out of hours. There's the air ambulance. There's a whole load of stuff that needs to happen really well, and it's expensive, it's inefficient, and it absolutely should be done, because it's really important. The NHS is not a business in the business of making money. That's not what it's for. It's to provide care. And where I work, intensive care medicine has got 3 words. Intensive, so it happens any time, unplanned. It's got the word medicine, and yes, a lot of that can be replaced by AI, which we might talk about in other things, but it's got the word care as well, and that's super important. In terms of private medicine, yes, of course, it's right. If you're incentivized to make money, you will do the things which do that most effectively. They are the lower risk cases, for example, and the other things. That's absolutely true. But then you need a system when things go wrong. We get transfers in from the private sector and so on. But that's not to say there isn't a role for that. but I think the way it's set up is really important. So in the Australian model, for example, you have the same standards of care pretty much in private sector or public sector, but the carpet is nicer and the food is nicer and you've got a private room and you've got a nice TV on the wall, a coffee machine. But the actual stuff you're having is kind of the same.
Sure.
You're just changing the experience almost. And the way they set it up there is it actually decompresses the public system, because anyone who's in work pretty much has health insurance, and they therefore have their planned low-risk surgeries in other places, or an MRI, in a supermarket next to a coffee shop, rather than on a congested site where you can't park, where it's hot, etc. So I think there's a way to do it well, which is still fair for people, and equity is super important. I don't know whether that always happens here, and I think partially because we're a bit nervous about even talking about collaboration, if you like.
Yeah, it feels like whenever anybody talks about private healthcare, there's this massive shame and guilt that comes with it. I've spoken to a friend of mine, she's got an autoimmune condition, and she was like, it was almost like she was coming out to me. She was like really kind of like, and she was like, had to go private because, I wasn't, the time was of the essence and this, that, and the other. But, I love the NHS and I do, and I'm a piece of shit really, actually, for doing it. And it feels like there's this shame. And is that different in your experience in someone like Australia?
Yeah, I think so. It's more accepted and standard, and I guess important to say I don't do private work. There isn't intensive care private work really. Well, there is some in London and some other places, but it's not something I do. But I think I'm not saying it's right or wrong, but it needs to be in that conversation. And actually, the way the waiting lists are being reduced now is by collaborating with some industry. So it's already happening. It's just we need transparency about that. And for me, the most important thing is it doesn't denigrate the ability to provide care at the point of need, Bevan's famous saying, and it doesn't form a two-tier system. And there are ways of navigating that, I think, but in order to do so, you need to talk about it. You need to be honest and open about it.
Do you feel like we're a little bit more uneasy talking about it because we're in Wales and because
there feels like an ownership of it.
Yeah.
Right? Like, I feel like even when people do attack the Welsh NHS, it almost feels like an attack on Wales. If you hear somebody from outside of Wales being like, look at the Welsh NHS, the way I start singing Calon Lan as I'm like coming out of it, I'm like, it feels like there is a real ownership of the NHS here in Wales. Yeah,
that's true. Although, remember, the first NHS patient was actually a lady called Sylvia. She was treated in Manchester. It was the world's first NHS patient.
Thank you, Andy Burnham.
Wonder where she is now.
Well, weird fun fact, her grandson became a doctor and married Clement Attlee's grandson, who was also a doctor, and he was the Prime Minister at the time of 1948, the government forming the NHS. So
it's given nepotism. It's given nepo, baby. They hate it.
Yeah, I think there is that. It's almost a religion in Wales, isn't it?
Yeah.
And sometimes it feels a bit like criticising it is something you can't do. But this isn't about criticising it. It's about trying to give hope, or I'm not a big fan of the word hope, actually. It kind of is a little bit magical and mystical.
Do you need facts? You need a plan of action?
Yeah, I think a better word is probably is Mellerism, which is a George Eliot word.
Yeah. It's about me.
For audio listeners, the moment Dr. Matt said Mellerism, Mel touched her own chest with self-congratulation.
Like you were going to suggest the word anyway. I suppose another synonym for hope is me. I am hope.
Have you ever heard of delusions of grandeur? I believe I coined that phrase.
I genuinely didn't plan that. That's the first time that struck me. But
delightful.
I'm going to expose myself before I actually am there. Mel is a better word, you're right.
Which means, the world is neither good nor bad, but it can be impacted by human effort.
Yeah.
And I think that's where we are in the NHS. It's neither good nor bad. There are some amazing things about it. There's some not so amazing things about it. There are things we can do, and that doesn't mean it's the same as when Bevan was standing in Tredegar saying X, Y, and Z. It needs to be different, but there are things that can be done to make it better, I think.
I think having those conversations, having those grown-up conversations, we've talked about that in terms of being able to criticise the Welsh government and people within Wales as a young democracy being quite sort of, well, actually no, because that sort of like the foundations aren't strong enough. I suppose there's a similar point there.
Yeah, I think so. And Will mentioned about staff, for example, working in other sectors, and does that eat its own tail? The sickness rate in the NHS is terrible. It's over 6%. It's 3 times the normal national average sickness rate.
Wow.
And over a third of those are because of mental health issues, actually. It's not just bad backs, it's mental health. And it always strikes me as super weird that we can't do something about that. In fact, I've brought with me a little surprise thing to show you. This is something I found in the bin in the hospital I work in.
It's a binder.
It's a binder, old-style yellow pages. It's from 1966. And
The
it
New
describes...
Medical Teaching Centre, Cardiff. Okay.
So these are the plans.
It looks exactly the same.
The hospital. Yeah. But well, that's important. It does look the same.
Plans of Heath Hospital.
Plans of the Heath Hospital from 1966. But what's beautiful in here, if you read them, they're actually amazing. And, the building now is a tricky building, for patients and for staff. But the thoughts behind it, for example, there's an entire wing there for staff health and for staff well-being. And so, these things have been thought about for a long time. It'd be a bit like having a factory that, makes printers, and it can't make printers because its printer is broken, so it can't print out the invoices. Well, what it would do is get a new printer or fix the printer. The NHS has a staff sickness rate of 6%, and yet we can't, fix our own staff. Why is that? Perhaps, and this sounds controversial, should they be able to have care, earlier on in the waiting list, for example? And that's not nepotism. That's because if you've got a knee surgeon who can't operate because he's got a bad knee, well, if you give him a new knee, guess what? He'll give a lot of other people new knees a lot quicker. It'll reduce the waiting list itself. So I think there's something big to be said about staff well-being, staff illness, sickness rates and culture, as well as these efficiencies in terms of well-being hubs, for example.
Could I ask you about, you mentioned how patchwork the NHS governance is. One thing I noticed when I've spoke to people is one of the frustrations is that health boards, even clinicians in opposing health boards, can actually see each other often as rivals rather than colleagues. I'm not suggesting there would be anything untoward there, but it's sometimes I think a lot of good ideas go unadopted. Do you think that's a fair assessment?
Yeah, again, it's malaligned incentives. I'll give you an example. The NHS app in England, you can book GP appointments, you can rearrange things. In Wales, you can't at the minute. And I know some of the people working in NHS Digital, they're super talented, motivated people who really want to make things better. But there are 7 UHBs, 7 health boards in Wales, all with their own information governance departments who need to authorise everything. It's talk about inefficiencies. You would design that if you were looking for an inefficient system. So one thing I hope this government does do, which they've done about many things, is not be very tofu. I like tofu. I'm mostly vegetarian, but it effectively takes on the flavour of what's around it. It doesn't have its own flavour. It doesn't have its own confidence. And I hope they are bold, actually, and do things that are hard and do things that for some people are unpopular. That's what you should do. You shouldn't just be average in the middle because it suits nobody. So perhaps those 7 health boards, why not have 3? One for acute and scheduled care, one for planned elective care, one for community.
So don't have them as geographic areas, have them as areas of competency.
Yeah, possibly. It is more difficult than that. Wales isn't Greater Manchester, and there are real rurality issues that Mel and others know all about. So it has to be with nuance. But is 7 the right number to replicate all of those procedures? Mark Drakeford's been on this podcast and said there are too many hospitals. There's a hospital every 10 miles on the N4 corridor. That's a terrible way to design an efficient health service. It's a bit like having a big Tesco at the end of everyone's road. You wouldn't want that. You would want a smaller convenience shop. And it's not because the big Tesco is not better. In fact, sometimes it's worse than a small convenience shop. It takes longer to get the stuff you want.
It does.
You don't have relationships.
Yeah.
You can walk around it.
I know what I want. I need to get in and get out. You know what I mean?
You buy stuff you don't actually want.
Yeah, 100%. I have a little look at the F&F, the clothing bit. I don't need another candle. But now I'm walking out with 50 quid's worth of pillows. Do you know what I mean?
Who are you?
I'm out of control is what I am.
I'm Hope, Will. That's what she is.
I
She's
am
Hope.
Hope and Mellerism. I think we're going to get on to a little bit more about what the new government can do, because obviously we could see this as an exciting time for the Welsh NHS, maybe some change. But speaking of flavour, we've got no tofu for you, but we do have a little treat.
We do
don't
have
we?
a smorgasbord of snacks. So I suppose the adage with medical practitioners is an apple a day keeps you here. So speaking of big Tesco's, there's a little Tesco around the corner from us, and because of the heat wave recently, all of their fridges were broken.
Yes.
So I went in and genuinely I was going to put one apple on the table and we'd all take bites at it like we were apple bobbing. No,
At the same time,
No, at the same time, like a sort of like
Lady
a,
and the Tramp
like a
of
vegan
fruit.
Lady of the Tramp, yeah. But no apples. And the lady said, all our fridge is broken. We've had no deliveries. You're lucky we've got bananas. And I was like, I don't want bananas. I'm not really that lucky. So I found lots of apple adjacent things. So we have an apple snack pack.
Wonderful.
Pink Lady.
A selection of apple sweets, children's apple rice cakes, which are
Ooh.
delightful, and they're really, really nice. And you've got kids. Did your kids, when they were younger, snack on these?
Is it a good time to say I'm not a fan of apples?
Oh, yes.
You'll have to have the Welsh cakes. They really do keep the
like
doctor away.
some other candies.
Looks amazing.
There we go.
Looks
You know,
amazing.
like, let's
What a selection.
mix this
Wow.
up.
One thing I'm really interested in, Matt, is how involved politicians actually are in decision making. Like, we see the photos of them like shaking the hands, cutting the ribbon, going around a very, very clean hospital ward. But like, how involved are politicians actually when it comes to the goings on daily with the NHS?
Yeah, something I'd love your opinion on, actually. I've often thought that, is it weird that the system of politics we have has a non-expert as the lead of something? You know, a politician. Should there be a doctor as health minister and an ex-police or ex-security person? So I don't know. Are there other systems around the world that have that different setup to things? I don't know.
It is an odd one, isn't it? When you think something so important and vital and specialist to then the leader of it not be a specialist, and then also somebody who might change jobs because of the political winds have changed. You know, that does actually, when you look at it on paper, it sounds very uncomfortable, actually.
Yeah, I think so, and I think that's when it's almost the outlier. I remember when was it Tom Tugendhat, who used to be in the military, was obviously shadow defence minister, and you're like, oh, well, that makes sense. But
Yeah.
that's the outlier usually in these kind of situations. And I
Yeah.
suppose this is why I always find it mad that, like, you know, for example, recently Wes Streeting just going, I'm going to quit as health minister. Like, look after health. It's a big portfolio, but like health has just not got a boss for a while.
Yeah.
It seems mad that, especially with all those reshuffles, just to save the skin of the person above, going, right, well, now you're this person, now you're this person. It seems like a madly inefficient way of doing work.
I used to work for a Secretary of State, and it showed me actually how little influence they actually kind of have, to be honest with you. Obviously, they have a relationship with the civil service, with the advisors, and I suppose this was the Secretary of State for Wales, which is obviously a lot less specialist. Whereas I would really hope that somebody who is like has got health as their portfolio would have a lot of experts kind of feeding information to them, and I would hope swaying their decision making. I don't know.
Yeah, and we do have a strong team of experts from the Chief Medical Officer in Wales and others and so on. But I guess in terms of that day-to-day decision, going back to Bevan, you know, when the NHS was formed, it had this partnership model. So at every important meeting, you know, there is somebody representing the hospital and patients, for example. That was one reason the BMA took a long time to come on board with the NHS, actually. It was because of the feeling that devolution of power, if you want to call it that, or decision making has gone. And I think that has waned a lot in the last decade or so, if I'm honest. It's become much less so. I'm hopeful, or I'm Melleristic about the new government in terms of announcing this new elective surgery hub, for example. There is a really strong panel of clinical experts, and that should absolutely be the standard way to do it. We need to work in partnership and collaboration to do that. But patients need to be involved too. That's the other thing to say. You know, patients are why we are there. So that's another dimension to add in, I think, really.
So this hub, what will it actually look like? Does it just get more people around the table to discuss changes?
Yeah, this particular announcement today is around elective surgery hubs. So a place where you go to have your knee replaced or your hernia repaired, which doesn't have the complexity of a busy working hospital attached to it.
So is it basically like if, say, I was booked in for a hip replacement in the Heath, and there was a pile up on the M4 that the resources for my elective surgery, which was planned, would be allocated, understandably, to that other need. So the idea is to separate that off so it's a clearer, easier production line.
Spot on. And most university health boards or most hospitals try to do this anyway, but they do this internally. And of course, that's more difficult because they have to be everything to everyone. They have to think about primary care, community care, acute care, planned care. And so separating these elective surgery hubs off has been shown in other centres to improve efficiency, for example. But, there are big buts. Where do you get the staff from? Because, you still need staff to staff it. Beds don't care for people. It's people who care for people, not physical infrastructure. What happens if something goes wrong, if there's a complication? How do you do that? And like I said, the NHS isn't just a spreadsheet of waiting lists. There's so much stuff going on, from out of hospital cardiac arrests to mental health crises, that doesn't live on a spreadsheet waiting list. So I hope attention isn't entirely pulled away just to those planned surgical operations, for example.
When you were talking about what role should politicians have, I think for me it's always been we should be completely based on evidence-based policy anyway. So if you are drawing decisions from the best available evidence, the person at the top shouldn't necessarily need expertise in that because they should be drawing from the best ideas that we have. And that should also mean that you get continuity of policy over time. Be really interested to know. If there was one thing you could say, but actually this would make a really meaningful difference. It could be something small, could be something larger. Appreciate new hospitals, up-to-date resources, not having to rely on agency staff are quite broad. But is there anything specifically you go, this would actually be a really piece of low-hanging fruit that would make a meaningful difference?
Yeah, can I choose three things? And I say three things because you said evidence-based policy. We've all got our top three evidence-based papers, I'm sure. My top three are parachutes don't make money is one of them. So, there's a lot of charity-sponsored parachute jumps. There was an amazing paper looking into the costs of those to the NHS versus the money made. And actually, because people break their ankles, doing a sponsored parachute jump for the NHS is a terrible idea.
Oh, no.
You cost the NHS more than you earn. So that's probably my top paper.
Oh, no.
The next favourite one
Is it a bit like doing like a sponsored mugging to support the police?
Yes, something like that.
On Saturday, I was doing a hike for Macmillan, the cancer charity, and there was a very real point in the hike.
And you didn't put sun cream on.
Also that. There was a very real point in the hike. We were like, oh, imagine, because we saw the air ambulance go over. What a mug would you feel like if you were the one who had to be air ambulanced out of a hike for charity? Imagine. Yeah. I was like, it was bad. These are points you're like, also, you can never complain. During that walk, you're like, oh, my feet hurt.
I was in Llangennith and there was loads of people doing it by the beach and stuff, and some of them were looking not great.
Yeah.
Sort of, how far did you walk?
The 20 miles.
Yeah.
Oh, good.
Yeah.
Wow.
Yeah.
Wow. I know.
Yeah.
Nice.
It was.
It was in the electric hub. Electric hub. That's it. Elective hub.
Honestly, it was. But you do, and also everyone there, had like the reasons they were hiking and who they were hiking for, which is amazing. But it does really humble you when you're going, I can't complain. Can I? Yeah. I cannot complain. Yeah, I'm fine. I know I've got blood trickling down my legs, but I'm fine. It's all good. So maybe never do that again.
Well,
I'm hearing from this paper.
I'll have to look at the evidence for walking, but parachute jumps are definitely.
Parachute. Okay, I'm going to tick that off my list.
No sponsored parachute jumps.
That's fine.
But there is one paper that looked at the most impactful interventions we can have, and actually none of them were medical interventions. They're not operations. They're not tablets. They are public health interventions. They are things actually that Wales is somewhat led the way with in the past. The 20 miles an hour we've talked about in this podcast a lot. The opt-in versus opt-out for organ donation, for example. And there are lots of others. There's the Cardiff violence reduction strategy to try and reduce violent injuries, for example.
That was the movement towards plastic in Cardiff City Centre rather than glass, was it?
Yeah, that was part of it. And actually, that was coordinated by a group in Cardiff University that's had a global impact on violence reduction. And so what I'm trying to say is I don't want to have a job in the future. I don't want there need to be an NHS intensive care unit. It should be about prevention. But there's a lot talked about move into the community. But this is different. This is, a step further. For example, the complete smoking ban. My daughter will never be allowed legally to buy a cigarette. That's an amazing public health intervention. So if there's one thing that can be done, yes, move to community, etc., but actually something even more powerful than that. And that's when the government needs to be not tofu. They need to do these things which are, in inverted commas, unpopular or brave, really, to do, I think.
Tofu getting a real slamming on the podcast.
I really wish I got some tofu. And that's a tricky time to be that, to be brave in this world where it feels incredibly divided. And obviously there's bad faith actors who are really sort of making money and getting political power from being provocative, if there's not so less spiky word for it. Like, do you feel like that's a possibility? Do you feel like that's the swing back from this kind of very divisive politics of people going, well, actually, this is my vision and we're going to do it?
Yeah, well, I think people are brave about some things. There's a lot of talk about digital being the salvation, for example. I've coined the term techno-salvation bollocks, which, every time there's a problem, including the NHS, the solution is, AI. Penny Dash in NHS England, for example, just last week did a conference speech where she said, we don't want clumsy, dirty hands inside people. We want robotics and AI. She kind of insinuated a lot of healthcare can be entirely replaced without people, actually.
Also, what a choice of words. Yeah. Do you know what I mean? What an insulting...
Specialist surgeon or midwife.
Yeah, exactly.
Yeah. Clumsy, dirty hands was the
clumsy, dirty hands.
Yeah. So there's a lot
also, I'm sorry, but the reason we, you're not going to suddenly have just all these robotic arms just...
No. Also, I'd prefer...
Spleen. Got it.
There's an element of human responsibility there as well. When you got somebody who understands the meaning of a life, right? I would almost prefer, and I'm not speaking for everybody, I would prefer somebody, if I am completely at their mercy, somebody who understands that I am a living human and who might want to save me, other than just a robot, just, poking things
The
at me.
idea that we need to remove hands from inside human bodies before we digitise people's addresses is absolutely insane.
But, but also, this makes it sound like there's just some rando off the street who's been brought in. What an insult to the actual people who are doing this work.
We also know what technology is like. We'll be halfway through a sort of spleen surgery. Has anyone got a charger? Has anyone got a spare charger for the spleen robot? It's like he's run out of charge. Blinking red light.
Oh no, they're playing disco.
Yeah, and it's the same clumsy, dirty hands that you want to hold somebody else's of, when somebody's dying or when somebody's crying, for example. So
I don't want ChatGPT telling me I'm dying.
Yeah, let's get Grok in the hospice. That's going to be brilliant, isn't it?
I think that might be both the bleakest thing you've ever said, Grok in the hospice, and also a great death metal band name.
Grok in the hospice.
Grok in the hospice. Let's start a band.
Yeah. I mean, man, that's so horrid, and that must be so disconcerting as well or demoralising even for the people working within the NHS, hearing that kind of shit coming from people who are meant to be making a change.
Yeah, and I'm all for technology. I'm a technophile. I love technology, and it can absolutely empower people, but it should be there to do that, not entirely to replace. There are some tasks maybe, but certainly not that. And there's also a trend of taskification in medicine, chopping things up into individual tasks, which basically just amputates judgment. There are certain things which you can do in a discreet way, but there are certain things you absolutely cannot. So, those are two, I think, big risks. And I guess the other thing to say, the move to the community, which absolutely is needed, absolutely, it's a brilliant idea. it hasn't been able to be achieved for the last 20 years. Every policy pretty much has
Everyone said prevention's better than cure.
Better than cure, and it's not
new
possible.
concept.
And even worse than that, what it does tend to do is actually surface unmet need. There's a great law described by a GP in West Wales, actually, called Dr. Tudor Jones. He described something called the inverse care law, where the people who most need access to care are the ones least likely to be able to access it. And actually what a shift to a community may well do is actually surface that unmet need. So the thought it's going to save all of the financials of the NHS.
It'll just identify more things that are slipping through the net.
Yeah, I think so. Yeah.
That is so bleak. So stop parachuting. Don't over promise on AI and tech, and don't put all your hopes that just simply moving into primary care rather than secondary care will be the answer to all our problems.
Yeah, so I think the real answers are think about those big impactful public health interventions that Wales has already led with in many ways and be brave about those things. Look after your staff, sort out this 6% sickness rate, and there are perhaps ways to do that, thinking about allowing people to access care earlier, for example, preventing them in the first place. Absolutely embrace digital to help those people who are already there, and think about which of those 4 methods that you really want to use to have a working healthcare system. Do you tax more? Do you collaborate? Do you become more efficient, or do you ration? And I don't think there's a right or a wrong way, but there needs to be honesty about those 4 methods. But there is Mellerism. There's absolutely Mellerism. There are ways to make this better, which maybe have started. I'm hopeful. I am hopeful. But I think you need to think about those other things too.
Completely removing party politics out of it, does the fact that there is a new government mean that there can actually be effective changes, or does the system as it stands tie their hands a little bit?
No, I think people look for change when there are issues, but I think it needs change with leadership, doesn't it? It needs both of those things at the same time, and there's always a good time, a fresh start to do that. So, yeah, I hope so.
Can I ask you something?
Yeah.
During COVID, people in ICU were really the front line, not just in dealing with the pandemic, but also the front line of a new disease, wasn't it? And that, I remember speaking to ICU nurses and doctors about how really in real time you were working out how best to treat something you hadn't seen before in that form. And I remember some of the original ideas that if somebody has those kind of lung issues, you try and make them wet, make it very wet in their lungs. But actually they found that really had the opposite effect. Then you found different steroids, having people on their front. How was it to be not only the kind of, oh my God, we don't know how to treat this, but was there a weird kind of professional excitement at the idea that actually, if you can work out how to make this better, the whole world suddenly gets a lot more functional?
Yeah, I think COVID was one of those tricky times which was absolutely terrible. It was like it was on the news. There's no conspiracy. It was awful. There are songs I cannot listen to because they were played at the bedsides of patients and families. And at the same time, it's a time where actually the NHS kind of, in a weird way, came to life. There was autonomy to do stuff, to make changes.
You could get that wall taken down if you needed it.
Without bureaucracy, teams came together. That may have been different in different places, and it was different in wave 1 and wave 2 and so on. But the science is fascinating. And I think a lot of people kind of got the public, I've got this title of public engagement in medicine. I think there's one thing we've learned from COVID is that public engagement needs to be better. On the next pandemics, there will be another pandemic. We need to admit uncertainty, not pretend we have all the answers. The 3 most important words in life are probably I love you. 3 most important words in medicine are I don't know. And it's really important to say I don't know, because it then gives you the permission to go and try and find out.
Manages expectations as well, doesn't it?
Yeah.
I think this idea that kind of medical staff are just infallible
Yeah.
is really, I think in journalism, it's very powerful to say we don't know this and we don't know this yet, but this is how we're trying to find out.
Yeah, and I think that probably wasn't said enough, if I'm honest. And I know governments want to give very definitive messages in catastrophes, but you've got to bring in nuance sometimes.
And people can smell it, right? I think people know, we always say in comedy, right? There's audiences who, they know when you're not telling the truth, but there's a little bit of, leeway because they're enjoying the story and so on. They can sense when something is completely inauthentic to who you are. I think the public aren't stupid. And I think they know when a government or a doctor even doesn't have a clue and is bullshitting you, right? And they'll have more trust in you if you say, this is the information we do have, the rest we're working out as we go.
Yeah, and equally then in the pandemic, the science is crazy. We went from no vaccine to a vaccine in less time than a term of a pregnancy. That's unheard of scientific advancement, and that's now going to impact a load of other diseases, from preventing cancer through vaccination, through malaria.
Of how the techniques to develop that vaccine.
Spot on. And there's a lot of dis and misinformation and loss of trust in institutions, but the facts don't lie. That science is there. And Wales actually played a huge part in eradication of polio. When I was in medical school, there was an epidemiologist called Dr. Norman Vetter who played a massive part in that, for example. And this could be as big as that. So, yeah, absolutely terrible experience for patients and families. Some still going through it because of long COVID and losing people they love. And equally showing what a health system can do when it's under pressure.
We've got an ageing population, so there's going to be more people needing treatment and less people to treat them. We know that there's huge pressures in all sorts of ways. Can you explain to listeners why they should have hope for the future of healthcare in Wales?
Yeah, I think you need to have hope because, first of all, we need to remember how lucky we are that we have a health system which, although it should be better, that it works. When my dad was born, that didn't exist. And in a generation or two, it's revolutionised. The things Nye Bevan had in Tredegar, 4 things in his hand. Now we have cancer treatments which cost £250,000, which do amazing things. We have transplants. We have amazing air ambulances that can save lives from crash. It's an amazing thing. What we need to do now is less so solve just the medicine, but solves the systems and the incentives behind it. And maybe that'll be tricky. But I think it's something that we can do.
So very hopeful note to end on. Matt, thank you so much for joining us. And we haven't mentioned you are an author. Tell us a little bit about your books.
Yeah, so I describe myself as a doctor, but I have written books. I've written 3 books. The first is called Critical. It's about what the intensive care unit is, and it's based around a story of a little 12-year-old girl called Vivi, who was the world's first patient in intensive care. And she had polio in 1952 and lived, fell in love. She got married and she survived thanks to this new invented place called the intensive care unit. The second book is called One Medicine, and it shows what we can learn if humans and animals work together in understanding science and medicine. How a giraffe breathes can help with asthma, why a kangaroo has 3 vaginas, and what it can teach us about IVF, for
Let's
example.
expand on that.
I think they already have.
And your third book, I'm so sorry about these. It's awful.
Third book is called A Second Act, and it follows the story of 10 patients, all of which who have died, or in other words, their heart has stopped, and yet they lived from all different causes, from being struck by lightning, being frozen to death, and what lessons on life they can teach us. And spoiler alert, it ends with my own funeral.
There we go. Well, thank you so much, Matt. Thank you for joining us. And I feel very Melleristic, actually, you might say.
I feel nauseous.
I feel Robinistic as well. Yeah, Matt, thank you so much. This has been absolutely brilliant. Thank you very much. How can people find you online and things like that?
Yeah, all the usual social places, and the books are in all good and bad bookshops.
Great.
Brilliant. We'll put
Dr. Matt Morgan.
There you go. Thank you so much. I've been Mel Owen.
I've been Robin Morgan.
I'm Will Hayward.
I've been Matt Morgan.
Thank you.
Ta-ra.